to intra-op, the best part of peri-op, or some kind of bias. Alright, so members of the surgical team. People don't think of the patient as a member, but they're a member of the surgical team. Then you have circulating nurses. Those are the non-sterile people in the room. They're the ones that get the patient from pre-op, communicate with the pre-op nurse, help position the patient, make sure everything is just right, do all the documenting and everything. The circulating nurse is really the one in charge of the room because, sorry, I just ran up and down the steps twice. Because they have the eyes to look and make sure that no sterile technique isn't being broken. They're monitoring blood, blood loss, urine output, all of the things. Yes, the CRNA, the anesthesia person's also monitoring that, but it's up to the circulating nurse to have her eyes open at all times, monitoring for breaks in sterile technique and everything. Okay? A scrub tech or a surgical technologist is the person that's at the table that passes the instruments to the surgeon. Registered nurse first assistant is the one that helps the surgeon, usually opposite side of the table. They help sew and tie vessels and close at the end once the surgeon leaves. And then the certified nurse anesthetist is the one that's at the head of the table giving the patient anesthesia, or if they're not getting general anesthesia, they're monitoring the patient, giving them sedation. They control the airway, all of that. The anesthesiologist is the one that makes all the money for controlling the airway, but it's not really in the room. No, the anesthesiologist has a lot of responsibility. They usually have about 4 rooms that they're in charge of. And so they really depend on those CRNAs to keep that patient alive, to monitor their airway and make sure everything is just right with that patient. And then the surgeon, we know what he does. So lots of people, and then, depending on the surgery, there can be all kinds of other people in there. There could be x-ray, there can be someone with a cell saver in there, all kinds of things, but these are the main people. All right, so to prevent infection, we have to think about different surgical environments that we're in. So you've got the unrestricted zone, and this is important for y'all to know, ding ding. Unrestricted zone is just like the hall corridor in the hospital. So just, you're out there, everybody's just willy-nilly in their clothes, you don't have to have on scrubs, it's where the patient and their patients and their family members walk, just plain old hallway, okay? Semi-restricted zone is required to have scrubs on and a cap, a surgical hat. And that is typically, once you go, every single OR in the world will have double doors right before you walk back into the operating room. As soon as you walk back in through those double doors, you've got to have scrubs on and a OR cap, okay? If you're actually in the operating room suites, you have to have a scrub cap, scrubs on, a mask, shoe covers if you're smart. Shoe covers are not required. However, if you ever, are y'all gonna get to observe in OR at all? Okay, yes, he told me, that's good. Well,
I was the only one with covers on.
Okay, yeah, so if you're smart, you're gonna wear shoe covers because you don't wanna take a piece of meat home in your car, right? So you get out and you're like, what is that? And it's probably, a piece of a colon or something, I don't know. That'll stick to the bottom of your tennis shoe or whatever. You don't want to carry that out with you. So wear shoe covers, right? And then just take them off before you leave. Then another thing that we do to prevent infection is surgical asepsis. Now, surgical asepsis is a little bit different than what you guys will learn when y'all start doing sterile intro and all of that. Because with surgical asepsis, people are wearing gowns and it's a little bit different. The principle is still the same, only sterile can touch sterile and non-sterile can touch non-sterile. There's a little more to it though when you're actually in the operating room than that, but the principle is good, and y'all will get that. And then there's environmental controls. So what can we do environmentally to help this patient, to prevent this patient from getting an infection?
Make the room cold.
Make the room cold? That's a myth, that the ORs are cold because it helps cut down on bacteria. That's just a myth. It's usually for the comfort of the people working in there. The surgeon, everybody at the table gets really hot with those big OR lights over, so it's really for comfort measures. What we can do though is, because the room's gonna be cold, we can warm the patient in other ways. How can we do that?
They have a blower.
Yep, a bear hugger, or there's different brand names for it, but yeah, it's the forced air warmers that'll connect to little blankets that go over them and everything. So yes, that. What else can we do?
We use warm fluid.
Warm fluids and put it through a warmer. What else?
With a HEPA filter counted for environmental control?
No, not necessarily. Now, if you're trying to get the smoke out of the OR, but that's not really an infection thing. But yeah, so we may use different things to evacuate the smoke. So you may see that, but it's not for an infection. Another thing, warm blankets. So anytime somebody goes into the OR, they're immediately going to be bombarded with warm blankets put on them, and then we're going to quickly start some type of active warming. Active warming means you've got some type of device. You're either giving them warm fluids, it's going through a warmer, you're doing a forced air warmer or something like that. There's all kinds of devices. You can put something on the bed that circulates warm water through it for them to lay on to keep them warm. So that's all active warming. Passive warming is turning the temp up in the room, giving them warm blankets, things like that. Okay? All right. So here's some guidelines for surgical asepsis. This is going to help y'all when y'all start this in a couple of weeks. Make sure that all of the materials that come in contact with the surgical wound is sterile, and everything that's on the sterile field is sterile. Well, that's a novel idea, right? But you'd be surprised how often that gets broken. Gowns are considered sterile only from like the waist to the chest and up to the elbows. You'd be surprised how many people walk around with they have their gown on and their gloves on, and they walk like this. Now, is that sterile? Right? They're propping their arms. That is not sterile. You'll see that on TV also. Because up under the arm sterile? No, it's not. So if you ever do get to observe, you'll be able to see things like, that's not sterile. Make sure that the sterile drapes are it's only considered sterile if it's on top of the table. So if you have a table here, and this one is really important for y'all to understand. If you have a table, because this is going to affect all of your sterile procedures you're about to do in skills. You cannot reach this way and pull the table, okay? You have to place your sterile gloved hands on top of the field and pull it toward you, okay? Cannot reach up under, because anything off the edge of the table is not sterile, okay? It's considered contaminated. Let's see. Make sure that when you're dispensing items onto the field, that you're opening them in a way so that you're not contaminating. So if you're opening something onto the field, you have to hold it above the field and open it very carefully so that it doesn't touch anything non-sterile. When the surgical team is rotating around, because sometimes the surgeon will say, swap sides with me, because he wants to see a better angle or a different angle. As you meet each other, you're both sterile. You either have to face each other sterile to sterile, or you face each other back to back. Okay? Never sterile to non-sterile. Then again, you're gonna keep movement to a minimum in the OR. However, again, sometimes you do have to move around the area. But you want to make sure that you maintain that 1 foot area. The circulator lots of times will have to open new equipment or supplies to the surgical nurse or the surge tech. And so she just has to maintain that 1 foot distance around the sterile field. see if there's anything super important. If you ever think, you always keep your eyes on the sterile field. This is gonna be important for y'all when y'all start doing your sterile procedure, your sterile skills. Never turn your back to your sterile field. Even if it's just like to get hand hygiene. Oh, I'm getting hand hygiene now. Never do that. Make sure that you just step to the side so that your sterile field's always in view, okay? That'll cause you to have to repeat some of these sterile skills that you're gonna do if you turn your back to your field, okay? And you always wanna open all of your stuff as close to the time for the procedure as possible. That'll help, that'll affect you in the hospital also. If you're doing anything sterile, you're not gonna go in there and open up everything an hour before you plan on using it and leave it, right? Because A, it's open too long, but B, you've taken your eyes off of it, okay? If you ever take your eyes off your sterile field, it has to be chunked, okay? It's no good anymore. Alright, so intra-op assessment. As they're rolling into the OR, you're gonna make sure that you do a quick clinical assessment. This is typically gonna be the circulator and the CRNA that's gonna do this, because the others are actually getting ready for the surgery, right? Getting all the equipment ready and the instruments and all of that. So the circulator will do an assessment. It's basically gonna be a quick skin assessment. We're gonna know if this patient has any bruises or abrasions, because we don't want to get blamed for that after the procedure. So if there's any bruises or abrasions or anything abnormal, we're going to document that before surgery. You're also going to do a quick respiratory and cardiovascular assessment on these patients. And then you want to know, I'm going to skip skin integrity for just a second. You want to know about their joint function. So if you can, get the patient, especially if you know that you're gonna have to put them in like stirrups or something that they have to have a really good range of motion in their hips and stuff like that, get them to bend their legs and kind of move their legs around so you kind of have an idea. Because are we ever gonna force a leg to go a certain way? No, no, we never wanna force it, so we wanna know ahead of time. Because if someone does not have a great range of motion and we know we need to have them in those big old stirrups, we're gonna have to improvise. We're gonna have to get some other equipment. That one leg may have to be kind of straight out and the other one bent, so we're just gonna have to work with it. So it's good to know ahead of time so you can get what you need. Skin integrity, again, you wanna look at their skin. Does it look very fragile and thin? If so, you need to make sure that you're taking precautions and you're padding and doing all the things, positioning appropriately. We don't want to pull that patient up on the bed. We want to be very careful as we're sliding them so they don't get skin tears. All right, so intraoperative care. So we're talking about physical preparation right now. So what all we have to do? What are the things, maybe I've just seen on TV, what all you have to do to get somebody ready for surgery once they're in the OR?
Surgical prep?
Yes, you have to do a surgical prep. That's usually gonna be betadine. Most of the time now we use a chlorhexidine solution, ChlorPrep, something like that. Yes, you gotta do a prep. What else? Before you ever do the prep, what are you doing? Yeah, they're going to sleep, but what are we doing once they're asleep and their airway is protected and all of that? Then it's on, right? It's a scurry. We're gonna start positioning them, getting all of the equipment, making sure that they're in the right position on the bed, all of the things. Then we're gonna do their surgical prep. Then they've got to get draped. All of those things have to take place before we ever start the surgery, okay? Then we're also going to do a timeout. We've already talked a little bit about intraoperative warming. We will do that before they ever get prepped or positioned. I should move that down after that. Before they are positioned or prepped, we're gonna make sure they have all the warming devices on them, okay? Because then we're gonna situate those depending on what type of surgery they're having, and then we'll know where to prep and all of that. So that's gotta be on there first. You don't wanna have to surgery, climb up under the drapes and all that stuff and try to get warmers on a patient because they're getting too cold. So always do that ahead of time. Again, we're gonna check for allergies or any sensitivities before we do any type of prep, put any gloves on them or anything like that. And then prevention of wrong procedure or site. How are we gonna do that in the OR? Somebody said it earlier.
Read it all.
Yes, but what are we reading? What are we doing when we do that?
The order, like read the order.
No, somebody said it.
Timeout.
Time out, yes. You're gonna do a timeout, which is you're reading the consent, you're looking at the order, you're checking the patient's armband, you're doing all of that. Is this the first time you're checking the patient's armband?
Oh, no.
No, you are checking that patient's armband before you ever leave the pre-op area. You're checking it again once they get into the room. The CRNA will check it again once your patient's over on the bed before they put them to sleep. All of the things, there's lots of times when that armband will be checked. But then we're also gonna check it as we're doing the timeout. We're gonna look at the consent, we're gonna read off the patient's name, somebody's gonna be looking at their armband while we're doing it. We're gonna talk about the procedure, who's supposed to be doing it, if it's a unilateral, is it the right leg, is it the left leg, whatever it is, and we're gonna make sure that if it is a unilateral surgery, that it's got the mark on there, okay? It's a big deal. There's been lots of wrong site surgeries. Okay, so anesthesia. What is general anesthesia?
Completely under.
Yes, they're completely asleep. They lose all reflexes. They're completely out of it, okay? So they can't protect themselves, right? What about regional anesthesia?
Just a part of the body.
Yeah, it's just a part of your body, but it is a larger area. If someone's having a regional anesthesia, so some people may have a spinal when they're having a C-section or different types of surgery. Some people may have like an axilla block if they're having shoulder surgery or arm surgery. And what a regional anesthesia does is it blocks the entire nerve pathway coming from the spinal cord, okay? That's important to know because that's different than local anesthesia. So remember, regional is an entire nerve pathway from the spinal cord, okay? Local anesthesia is just blocking one area of the body. So I may have a local on my hand or something, and so that's just blocking the peripheral nerves. It's not an entire nerve pathway like regional, it's just the peripheral nerves. All right, sometimes people may have general anesthesia and a regional or a local for pain control after surgery. Okay, all right, what is moderate or conscious sedation?
They're just a little out of it.
Yeah, they can still respond appropriately to you, but they're sedated, they're resting comfortably, but if you call their name, they can answer. If they can't, they've slipped into deep sedation, and that's not where we want them to be. If we're going for moderate sedation. So they should be able to respond, maintain their own airway, and keep their vital signs stable. Okay? All right.
When you have your wisdom teeth taken out, what kind of sedation?
That is conscious sedation that you get.
You don't respond.
You do, you just don't remember. If somebody has conscious sedation, they're not gonna remember after. You may have an entire conversation with them and they're not gonna remember a thing about it after, usually. Okay, so now we need to talk about the ASA classifications. These are the anesthesia classifications. And this is how anesthesiologists determine how stable this patient is and what type of care they're gonna need intraoperatively, okay? I've got a little chart and I'll show it to you in just a second. So we've determined that, the classification, now we've positioned the patient, and then we've gotta make sure that we document everything that happens in the OR. Everything, from the time you roll through the door, indoor time. From the time you get the patient ready and the procedure starts, you have to put the start time. and so on. If there's different types of devices being used, like maybe tourniquets or whatever, you have to document tourniquet time, because you don't wanna leave the tourniquet up too long. All of those things, lots and lots of documentation. Also, again, we already talked about if the patient has any type of lesions or abrasions or anything like that, you're documenting that. Any special equipment used, if they get any implants, you're documenting. So the circulator has a big job. They have a lot going on, and the surgeon always thinks he's in charge, but it's really the circulator that's in charge. Everybody's at her mercy, or his mercy. Okay, so, then, let's move on. Okay, here's the ASA classification. As you can see, and this is important for y'all to know, ding, ding, ding. AS1 is gonna be the healthiest of the patients, okay? They don't have any, comorbidities. They're totally fine, okay? And then you see it goes all the way to ASA6, where you've got a brain dead patient, probably in for procurement, right? So there's a lot of room in between. Typically, we have a lot of healthy patients, but typically they're gonna be around 2, 3, 4, somewhere in there, okay? One's getting a lot of, coming in for surgery. Even if they just have hypertension, or they are diabetic, they're gonna automatically be an ASA2. Any questions about that? Make sure y'all know this. Okay, so some intraoperative complications. Y'all may have heard about anesthesia awareness. Have y'all ever heard of that? Where somebody says, I woke up during my surgery. That was a real thing. But now that doesn't really happen, because now we have monitors that we place on all the patients if they're getting general anesthesia. It's called a BIS, and it monitors their brain waves, and if the number starts you want it at a certain number. If it starts increasing during surgery, you know that the patient's getting light, or their anesthesia is getting light, so they know to give them more, so that anesthesia awareness doesn't happen.
You said it's called a BIS, like a
Yes, BIS, but that's just a name brand. You don't have to know that. I'm sure there's other brands out there. That's just the one I know. Okay, so just know that it monitors their brain waves, and if they start getting light, it lets them know. It lets anesthesia know that they need to give them some more. Okay, nausea and vomiting, that's a real problem. We've already said why is nausea and vomiting so important? Aspiration immediately, but also what?
tearing of the surgery.
Yes, opening up that incision. Anaphylaxis, for whatever reason, they may say, no, I'm not allergic to anything, but then they have this massive anaphylactic reaction in the OR. Well, it's because they were probably exposed to things they've never been exposed to before, so they wouldn't have known that they were allergic to it. So it does happen. Hypoxia and respiratory complications, because we are controlling these people's airway lots of times. And if they already have lung issues, maybe they have pneumonia or something like that, it can exacerbate it. And then we want to make sure that they don't get injured, because again, these people are at our mercy, right? They can't protect themselves. If they start to fall off the bed, what's gonna happen? They're gonna fall off the bed. They're gonna fall, unless someone catches them. They're not gonna be able to catch themselves or keep themselves from falling off the bed. So you've gotta make sure that you've got them strapped and secured and padded and all of the things, so that they don't get injured during surgery. Hypothermia is a big thing. If you pull up anything anywhere about surgery, intra-op hypothermia is gonna be a big thing that comes up all the time. Why? Because, right, and they're under general anesthesia, or the room's cold and they've got lots of their body exposed. And then if it's a big abdominal surgery, now their insides are exposed too, right? So they can't control, they can't regulate their temperature, and it's worse with the very young and what? Very old patients. Infection we also worry about, so we're gonna make sure that we're maintaining, surgical asepsis, but we're also giving that antibiotic. We are making sure that we keep them warm, because if they get too cold, it's gonna increase their chances of infection. Why? Why do you think that is? Why would, so they have an abdominal surgery. Why, just because they got cold, would that increase their chances
All
of
the
infection?
efforts are spent towards warming your body up instead of.
No, it's mainly because what happens when you get cold to all your blood vessels?
They constrict.
They constrict, right? And so do we want everything constricting at that surgical site?
No,
No, because what's happening then?
so everything.
Yeah, you don't have good circulation to that area, so you can't heal, so your chances of infection is much greater, okay? If you're cold, if you're hypothermic. There's lots of other things that can happen with hypothermia.
I don't want to shut off on you.
Thank you. Okay, maybe that worked a little while ago, let's see. Okay, so there's lots of other things with hypothermia that can happen to these patients. They can have cardiac dysrhythmias, they can bleed a lot more if they're hypothermic. Lots and lots of bad things can happen if these patients are hypothermic. And when we talk about intraoperative hypothermia, we're talking about less than 36 degrees Celsius, which is about 96.8 Fahrenheit. Okay? And then the biggie that we worry about, malignant hyperthermia. Again, super duper rare, but when it happens, it's very important to know how to treat it. First thing you're gonna see typically is gonna be an increase in their expired CO2 and an increase in their heart rate. That's usually the very first thing that the CRNA or whoever is the head of the band is gonna notice. Their CO2 has gone up and their heart rate has gone up. Right, and then their muscles will become rigid. So if we're doing an abdominal surgery, they may all of a sudden, all their guts are coming out of the wound. They're not relaxed anymore because they've gotten very rigid, okay? So that's gonna be the next thing. Hyperthermia is actually one of the later things that you're gonna see. They're not gonna all of a sudden pop a temp of 105 degrees. It's gonna be slowly, but yes, they will also get a temp of 105, okay? Something else you're gonna see, or greater, maybe even more than 105, something else that you're gonna see is dark urine. Why would you have dark urine, you think? Possibly, yeah, kind of, because of the muscle damage, okay? Because of all the rigidity of the skeletal muscles, you're getting some muscle damage, kind of like rhabdomyolysis, okay? Y'all know what that is? Okay? So that's kind of what's happening with these people, along with other things, but that's why you're seeing the dark urine. So it's really important, and do y'all know what triggers malignant hyperthermia? No. What triggers malignant hyperthermia? Huh?
Anesthesia.
Yes, what kind of anesthesia? There's certain things, succinylcholine, which is a muscle relaxant, paralytic, succinylcholine, y'all gotta know this, okay? And the inhalant gases that people get with anesthesia.
Like isotope.
No, like sevoflurane,
Okay,
isoflurane, stuff like that.
Any question?
Succinylcholine, SUCCINYLCHOLINE.
Somebody,
I won, the spelling bee.
Is that one less, is succinylcholine less used now because
It
ISO
is less used, but it's still used a lot. It's not as common, there's other drugs now, but it is still used a lot. You
A
will
lot of
still see
people are
it.
moving to ISO instead.
To what?
The ISO instead.
No, that's something different.
Okay.
Are these listed in the PowerPoint, or do we just need to know inhaling gases, or do we need to know specific?
You need to know succinylcholine and inhaled gases, that's all you have to know, you don't have to know specific gases. Okay, so now we know what causes malignant hyperthermia, how are we gonna treat it?
Dantrolene, is that how you pronounce it?
Yes, dantrolene. We're gonna treat it with dantrolene.
You tell what she does.
Absolutely, and we're gonna give it, there's probably a max dose. We're gonna give it until the patient gets a response, basically. I'm sure that in the packaging somewhere, there's probably a max dose of something, but you're not gonna say, oh, well, we've reached our max dose, we're not gonna give them anymore, because that is the only treatment for
I was like.
malignant
Thing
hyperthermia.
is, death.
So we're gonna keep giving it to them until they respond, but also what are we gonna be doing in the meantime?
Cooling them off.
Well, hopefully they're not coding yet.
Ice packs.
Ice packs, we're gonna be hopefully putting a cooling blanket on them, stuffing their axilla and growing with ice packs, doing cold fluids. We keep cold saline in the refrigerator for a reason, for this, for malignant hyperthermia, so that we can infuse cold fluids to try to get that temp down, okay? It's usually normal saline, can be lactated Rinkers, usually an isotonic solution though. Okay, so, what causes it?
Anesthesia.
Inhaling gases.
Inhale it and anesthesia.
Yes, y'all gotta know, not just anesthesia, y'all gotta know acetylcholine and inhaled gases. How do you treat it? With dantrolene, that's generic dantrolene, the brand name is Dantrium, but I'll always give you both of them. Usually the generic is what you're gonna need to know, okay? Any questions about that? Okay. So for older adults, we've already talked about, we have to take special precautions with the cardiovascular and pulmonary. Why?
Perfusion.
Yeah, because their perfusion's not as great, but why? Why is their perfusion less than when they were 30? Why just because they're old? What happens to the heart?
Because the muscle hurts.
Yeah, you're exactly right. It doesn't pump as well, and that's just a natural part of aging. It doesn't mean that they have heart failure or anything like that. Just a natural part of aging is that the lungs don't expand as well, the heart doesn't pump as well, okay? Same thing with tissue. Tissue is not as elastic as it used to be. So they can get injured easy, they can get abrasions and bruises and tears easily. What about their liver? Hopefully it's not gone. But yes, it doesn't metabolize as well anymore. Yes, so if their liver doesn't work as well anymore, they're not gonna metabolize the anesthetic agents as well. So it's gonna hang around for a long time. Same thing with kidneys. They're not gonna be able to filter out or excrete that anesthesia as well. Again, same with metabolism. Everything is kind of down once you get older. So they're not gonna be able to metabolize things as quickly. Especially some of these drugs that'll collect in fat tissue, they're not gonna be able to metabolize it as quickly.
Because they don't have it. Well, some of them do.
Some do.
My mother, no.
Okay, so some surgical positions, we're gonna talk about, I've just listed them here, but I've got a picture of all of them. Okay, so this is just supine, y'all know what supine is, okay? This dude's arms are tucked. Lots of times they're gonna be on boards that come out right here. But this one's tucked. They're probably tucking his arms because they wanna get close to his abdomen or his chest for whatever they're doing. Lateral, what kind of surgery do you think we'd be doing for lateral?
Colonoscopy.
Maybe, yes, colonoscopy, what else?
Something with the butt.
Huh?
Hip surgery.
Maybe, kidney surgery, that's a biggie that you'll see, lateral, you'll see some type of renal surgery. Okay, so prone, that's what, or back, could be, yes, back, or if it's just something that they've got a wound on the back of their leg or their heel or something, they'll have to go prone so that we can get to it, right? Do you see all of this right here? What are, do y'all know what those are? Pads. Yeah, it's chest pads. You've gotta pad that so that they can, their lungs can expand. They have to have those pads up under there. And with women, you have to be really careful when you're putting those there so you don't squish the boobs. Okay? You have to make sure that everything is positioned just right, or they'll end up with an injury. Okay. This is Fowler's. You'll see a lot of neurosurgeries and shoulder surgeries with this position. Lithotomy, guess what kind here?
OB.
GYN surgeries, also some anal and rectal cases will be done like this. Trendelenburg, it's where you're on your head. Why would you think that someone would be a Trendelenburg?
Foot surgery.
No.
The blood to come to the down, right?
Right, what are we trying to get to move up this way? Intestines. We want any organs down here to shift out. So typically we're gonna be operating down in this area if we put somebody in Trendelenburg. So a lot of the robotic procedures, they're in steep Trendelenburg because we're trying to get that colon to move up because we're working their uterus or whatever it is. Just know that if they're in Trendelenburg, they're usually working lower in the abdomen. Okay? Reverse Trendelenburg is the opposite. So you see we put a footboard here so the patient doesn't fly off the end of the bed. He's strapped on. I don't see a strap, but you should have straps also. But what do you think we're operating on this patient? Where are we operating? Upper abdomen. So gallbladder, liver. Okay? So, because we want everything to shift down. That's why we put them in this position. We want to have visualization without colon being all in the way. So we put them like this so that everything can shift down, hopefully. And y'all, it's important to know the difference between Trendelenburg and reverse Trendelenburg. Okay? Really important. People get those mixed up all the time. All right, jackknife. What kind of surgery do you think this would be?
Lower spine.
It could be spinal surgery or some type of rectal surgery. Lots of spine cases are done like this stuff. I know lots of nurses that will not get their back surgery done because they know that surgeon's gonna put them in this position. So they don't wanna have the surgery, they'll just suffer. Instead of being put in jackknife in the OR with all their people they work with. Okay.
I don't blame them.
Right?
I don't care.
They got to go somewhere else.
Different hospital?
Yeah.
Yes. Okay, so it's important while the patient is there, I mentioned this earlier, make sure you're keeping the family informed. Every hour or so you need to be calling out, updating them, everything's going well, you don't have to give them details or anything like that. They just wanna know that their loved one's okay, everything's going as expected. Alright, and then you want to, once the surgery is wrapping up or it's over, you wanna do another clinical evaluation. So another assessment on the same things you assessed before, making sure that they don't have any unexpected skin abrasions or tears or bruises. That their lungs are still good, their heart's still good, hopefully. Just a quick little assessment because that's important things that you're gonna need to pass on to the PACU nurse, which is post anesthesia care unit, nurse. That's where someone goes immediately after surgery. Alright, we need to know about blood loss, we need to know about drains, Foley catheters, all the things, anything that this patient may be leaving the OR with, we need to be ready to tell the PACU nurse about.